main topic. Also, application of human placenta extracellular matrix for making tissue flaps in an AV loop model. This is the arterious venous shunt model. I will show you an image of that. So we want to create tissue flaps which can be transplanted. This is a cooperation with the plastic surgery. And since I'm focusing on 3D bioprinting, I started to create a placenta extracellular matrix based bioink platform to develop new bioinks, which probably can fulfill the needs I've talked about before in future. So starting with my entry to using human placenta tissue, this is a tissue which is highly available because it's a clinical waste product after every birth, and it's human origin. It's mainly a young and healthy tissue. So therefore, we started to think about how we can isolate vasculature from human placenta to create vascular grafts. And this was a project in 2016 and 18 where we had to define the decellularization protocol, because you can isolate vasculature in different dimensions from the placenta tissue, and then it should be completely free of cells and cellular components by decellularization. And here we had a comparison of two detergents using Triton X or sodium dodecyl sulfate. So the process is that we isolate native vessel and then we put it into the decellularization cycle. So this is a combination of physical, chemical, and enzymatical treatments. So we freeze thaw our material, then we perfuse the material with detergents and other washing solutions. And after washing out the cells with these steps, we sterilize it without destroying the extracellular matrix, because this is which has an effect of the cells after using it as a prosthesis. So these vascular grafts were then washed and then used for in vivo and in vitro experiments. And what we also looked into was how the different detergents, the sodium dodecyl sulfate or the Triton-based washing steps, can have an effect on the matrix composition. So we do not want to destroy the extracellular matrix too much. We want to wash out the cells, but also keep as much as possible from the matrix. And we did that and analyzed that with proteomics. And we also made a macrophage polarization by seeding human macrophages on the tissue and see if they are dominantly be shifted into a pro-inflammatory or pro-regenerative state. It's called the M1, M2 state. Also in our in vivo application, we implanted those into a rat model. So we replaced a 2 centimeter long part of the aorta abdominalis of a Sprague-Dawley rat. And we could see that they were highly patent after and within 3 months and up to 3 or 4 months after implantation. And also we could observe functional remodeling, cell migration, and also functionality by contraction. But this is a natural material, which normally people would say we cannot further modify it. But there was another study where we said probably we can change biomechanical properties. We can change the smoothness of the graft surface to prevent further thrombotic effects of these materials. So what we did was that we improved the surface properties and the biomechanical strength with UV treatment while preserving cell migration and remodeling. And we could show that we can further tune mechanical properties of decellularized grafts with these methods, and they were still functional. And you could also see that with or without this, we call it here RUV treatment, because we used riboflavin as a mediator for oxidative stress to cross-link the materials during the UV cross-linking further. And we can see that the cells migrate well here with different stainings for smooth muscle cells and for different cell types, fibroblasts for migrating into the tissue. And we could also see with the myograph contractility, with the myograph system contractility of these grafts regained contractility. This was a cell-free graft we implanted, and after 4 weeks, they contracted, which is quite stunning for prosthesis if you implant it into a rat. So these were all grafts with a inner diameter of 2 to 4 millimeters, but they were quite short, so they're limited to 9 centimeters. So the idea was what else could we use as an arterial graft, and we thought about the artery from the umbilical cord. So this was the next phase that we isolated the umbilical cord artery, decellularized it, and used it then for studies, for example, that we also coated with nanographene. This was a collaboration with the University of Porto, that we can further modify this and have a quite long piece of a vascular graft. Also, we performed the pilot study, implanting it as a cardiac bypass, and we are using it for surgery training for our surgeons, which I want to give you 1 or 2 slides afterwards as well. The other way, going to even smaller vascular grafts, would be going in sub-millimeter grafts. So here you see decellularization process on the left side of grafts which are between 0.4 and 0.8 millimeters in inner diameter. And we were using here this so-called arterial venous loop. So you can see that we can loop the graft or replace a part of the loop, and then we put it into a chamber which is then filled with a matrix that we can have vascular sprouting into that matrix. And we, in this case, just wanted to see the patency. What we could see that we have roughly a little bit more than 70% patent grafts in this experiment in a sub-millimeter, what is quite good, I would say, because of the size of these grafts. The next thing, apart from the grafts, is, as I mentioned, creating a bioink. You have a typo, it's a biotinks, but it's a bioink. So for that, we are using different parts of the human placenta tissue, and then we process it for over 2 weeks with washing steps. So in the first week, we just wash the material, get rid of the blood, and then there are some other steps to get the cells out. And after that, we have a freeze-dried tissue, which can be further processed to create a bioink. So we have a solubilization step with an enzymatic treatment, and then we can create a so-called pre-gel, which is a powder, pre-gel powder, which can be rehydrated to a bioink. And this bioink can polymerize, so it can be used for 3D bioprinting. So this bioink can be used not only for bioprinting, it can also be used for surface coating because it improves cell adhesion. Sabrina had a good publication on this, where she showed that we can coat vascular grafts inside and improve endothelialization, re-endothelialization of these grafts in an in vitro bioreactor system, a perfusion system. Then I was telling you about the vascularized tissue flaps, and here you can see nicely that if you have the loop and this is filled with the ECM, then you can see that you have laterally sprouting from this vein graft into the matrix. And of course, it's a bioink, so we can have different shapes to be printed with this ink. Cells can be loaded to it. So you have different size and shapes. This would be a muscle fiber model or a pulmonary heart valve, or just some grids we printed, and this printed cylinder filled with the cells, which can then be treated in an in vitro setting. So for printing, we are using mainly our homemade printing systems. This is a FDM printer, which is completely rebuilt to have something like a syringe pump in front, and then you can have a mechanical extrusion driven bioprinting system. And we are printing with our gel into a support bath. Here you can see printing like multiple cylinders filled with fibroblasts, and it looks like this from the inside. This would be the cylinder, and if you look, this is completely filled with fibroblasts, and they are spreading. That is like the key effect or the key thing you want to see if you have cells printed, that they are not stay round shaped. They should spread and take over the material and maturate with the tissue. One example how we can also use it is that we change mechanical properties of the material. Here in this case, combining it with silk from the silkworm cocoons. So this is a mixture, and with you would have here the silk 60, a 2% solution filled with cells. Then you have the silk with a gelatin, and here you would have silk with a gelatin and the placenta ECM. And the idea is that we get mechanical properties from the silk, but the bioactivity and biological support for the cells from the ECM. And what we do see is that after 3 days already, only there where we have the ECM and not the gelatin alone, we can see that the cells start to sprout. And after 7 days, the whole tissue, the printed tissue sample or scaffold is really filled with and with the cells, and the cells are spreading through it. This is also an image of these 3 groups with the silk only, with silk with the gelatin and with the ECM. And only with the ECM you can see that the cells are sitting on top of the material inside and that they are spreading and forming a network. So the ECM supports in the 3D scaffold cellular growth. As a conclusion for these examples of my work, is that we have some potential of natural biomaterials, especially from the placental ECM hydrogels. We managed to develop different vascular grafts, and also we had a mixture of silk and gelatin and ECM bioinks, which show their high biological properties, I would say. Also, some preclinical models, and in future, of course, we want to see that we can bring these materials further into the direction of a clinical application. One thing I want to mention as well is using these materials, 3D printed or ex vivo models for surgical bypass training. This is what we started 2 years ago. So you can see here my colleagues preparing an ex vivo model. This is a pig heart where we can train our surgeons and medical students in performing coronary bypass surgery. And some parts will be printed, like you can have models from printed vasculature, or you can have the ex vivo. And also what we do is to have a measuring tool. We are measuring the cognitive load during the surgical training. So here you would have 3 measurements of the pupil size of the trainees. Like the expert would have a lower cognitive load performing a specific bypass surgery, and a trained person has a higher load because it's not that experienced, and an untrained person has a even highest load during the procedure. And this is a new tool we want to introduce to go into a surgical training and support it with an objective measurement. At the center, we have also a preclinical center, and this is where the students can then join master classes for cardiac surgery. This is a pig where we have a cardioplegie, so the movement arrest of the heart, and they can train here in our surgical theater on a pig before they go to the patient. Coming to one of the topics is showing that all this work is not possible without a network, without mentors, without colleagues and your students. So what I want to point out is that we as a team, we can achieve more. And you can see these are just a few people I put on from the last years, which really were involved in all the work you just saw. And therefore, it's very important that we go to conferences like the one in Miami, and that we go out of our comfort zone and try to meet as many people that we can work with them closely together. So my last slide would be on exactly this fact, that giving like my idea of how to create new contacts and make them collaborators. So my advice would be that we want to be visible when we present our work, as I'm doing here in the webinars, seminars, and conferences, that we enjoy that. The second thing is that we want to be mobile, and we want to go to different labs during our career, our scientific career. We want to attend international meetings. For my part, I changed 3 times the lab during my career. And now I'm settled at the medical university for since 2016. But in between, I also went for 1 year abroad to Boston to a university to also learn more about that. And so, what I already mentioned, when we go to conferences and in our daily routine, we should not get too comfortable. We want to step outside of our comfort zone regularly, that we keep being innovative and start to create something new. At conferences, we should not stay only with our groups. So please, if you see me in Miami, then say hello, and let's start a conversation. If I don't know you, even better. And so we should try to join new groups and go to social events, not only sticking together with our people we just came. So connecting research interests, not just people. So this is the other part, but I think most importantly, you should like the people you work with. So you should be connected also on a social level. Well, so in this case, we should engage the projects, international grants and applications, and use platforms as the Young Society to do that. That would be the best thing. And with this, I want to close.
So thank you very much, Carl, for this interesting overview about your research. And I really liked your last slide, because I think this is really important, especially when we are going to Miami and try to connect with new people. So are there any questions from the audience? Please feel free to unmute yourself or write your question into the chat.
I can start if you... Thank you very much, Carl, for this interesting presentation of your work. I have question on the scientific part of your work, especially from the regulatory point of view. I was wondering, is it easy to obtain placenta in Vienna, and do you know about the other countries?
Mhm. That's a good question. So it's human material, so you need an ethical agreement. You need a consent of the mothers, which provides the material. So, but on the other hand, it's a clinical waste product. You could not just take the material and sell it as it is. Like if you would like to use it in France, that I would, without any processing, just take it and send it to you. But since we are using it as a start material for a highly processed material, this is not a big issue. But of course, I had to have the national and from the university, the ethical committee to agree that we are using it for scientific purpose. And since this is a very has a high potential to be used in many labs. So we have collaborators already which are using it, and we also think about adding that we can use it for commercialization. But then you have to go through the process again. But there are a couple of companies which are using placenta material already. So it's possible, but you have to make it strict to the rules of the country, and then
Okay.
you can cover it.
And you are talking about the process. So for the second part of your project, you are lyophilized your tissue, you create bioink, and you use it to create new tissues. I was wondering, do you think that the lyophilization process can affect the immunogenicity of your placental matrix?
Definitely. So what you do change with the whole process with deserization and also with the freeze drying is that you wash out everything that's not strictly or strongly bound to your extracellular matrix. So, most of the growth factors are gone. So you're not isolating. If you want to isolate the growth factors from the tissue, then you would have another process. You would make an matrix extraction, which is more soft in case of the washing steps. But you would lose the mechanical strength or mechanical properties of the material. So it's in fact the freeze drying is helping you more with getting rid of some contaminations, I would say, and cellular components. But for the matrix components, it's not an issue. We all are using maybe collagen coatings for cell culture, and you buy them as a lyophilized sponge, and
Mm.
then you rehydrate it. So this is the exactly same thing. The only thing is that you have a combination of proteoglycans and structural proteins, fibronectin, and collagens, different types, which are mixed into this matrix depending on the tissue you got it from.
Yeah, but just my concern is about the structure. Since you're modifying this structure, I was wondering if, like, if you implant it, maybe macrophages will recognize that as a foreign body that will, that.
Mhm. What we saw, so we did some studies with macrophages, with human macrophages already on the material as vascular graft and as a coating. And what we do see is that you always have, when you put the cells on in the beginning, is a shift into the inflammatory phase, or like differentiation of the cells. You activate them, but after 3 days, they go strongly. They go into a regenerative phase. So it has an immunogenic potential, but in a regenerative way.
Okay. Okay.
Yeah.
I will have one last question and then I will let
No, it's
people.
good. Thank you.
One of the major challenge for bioprinting ECM when it's mixed with cells is the contraction of the construct during maturation.
Mhm.
Did you look at this in your work and how do you manage it?
Yeah. So there's a separate study we did on that, especially when you use fibroblasts. They are interacting strong with the external matrix. So what we can do is this, that we just simply change the concentration of our material. So you can print starting with a gel starting with 20 milligram per milliliters. This would be a 2% weight volume gel, but then you will have a strong contraction. That would be probably interesting if you want to have contraction and want to create little, like, organoids or something, because then they would shrink it down to a little scaffold. But we made tests with concentrations going up to 8%, 80 milligram per milliliters, and there the contraction is completely gone. The only thing that happens, if you work with fibroblasts, they can live with that because this is a strong environment then. And if you have cells which cannot be in such a dense matrix, you have to find the sweet spot with the concentration. The second thing you can do is further cross-linking. So we are using this riboflavin and UV cross-linking, which kills like 10% or 15% of your cells, but then you can also get rid of the contraction. But printing also kills a couple of percent of your cells. And then the third thing would be that you can mix it. You can make a composite with different polymers that you can also have something that gives you more stability for that. But in fact, we could really see that with increasing the concentration, cell viability is still good. But the growing cycle changes a little bit, so it takes longer for them to start being metabolic active. At the same time, they get then larger in their morphology. So I think it could be good if you create something more dense, that the cells take a little bit longer to adapt, but then the final result will be maybe stronger.
Okay. Thank you very much for your answers.
Thank you for the questions.
Okay, are there any more questions to Carl?
I was interested. You said that that in Vienna you could go for training on pig models, I guess, before plantation to humans. Is that just I assume just medical doctors, right? Can get this training, since I guess the purpose is to then go for humans, because I can see how that could also be valuable if you're doing anything in pig models, but you maybe want to train in cadavers first as well.
Yeah, so we do both. Whoever is interested, and if there's a class and there's a researcher coming, then that's also possible. Especially if it's about, as you mentioned, that there is something you want to test before it goes into a pig model. However, it's then you will also be included or will be connected with the surgeon who is then performing the procedure. So you would, but if you would come with the surgeon or want to look at the model and we test it here, then it's also possible. I'm also not an MD. I also did it, but the focus group is medical students and residents. But it depends if there's a need for someone working in a model, then we can have it here as well. So that's open, I would say.
Okay, then thank you. Due to time reasons, I would say we switch to Valentina.
Yes.
It's time to cross the Atlantic and go to Miami. So let me introduce to you Dr. Valentina, who serves as a research assistant professor in the Department of Biomedical Engineering at Florida International University. And she will present her work. So, Valentina, the screen is yours.
Yes, so Carl, funny enough, talked a little bit about mobility, but I've been at FIU like my whole research career, so I'm the opposite of what he recommends. But I see value in both things, as long as you do get out and see what other people are doing. So I did get my bachelor's, my master's, PhD, and did a brief postdoc here at FIU in the Department of Biomedical Engineering. And today I'm going to talk to you a little bit about some of the research that's going on here, but in my lab, but also overall at FIU, and opportunities for you to keep in mind when you come here, hopefully for this year's meeting. So this is a picture of the FIU library in the main campus, which is the highest point at FIU. But by the way, Miami is like completely and utterly flat. So if you come here this year and you see a hill, it's usually a garbage hill. We're like sea level or below sea level. But it's funny that this library is the highest point at FIU, not in Miami. Obviously, we have bigger skyscrapers, but FIU takes pride in that. So we're located in Miami, Florida. So we're here at the end of the Florida Peninsula, relatively close to everyone in Europe. And FIU has, this is a picture of Miami Bay. And FIU has two campuses. So the picture of the library is in the main campus, what we call MMC, which just stands for Modesto Main Campus. And then we also have a Biscayne Bay campus, so we literally have a campus on the bay. Unfortunately, that's not where I am because it would be nice to have an office. This is FIU right here at the bottom. If I can get my laser pointer to work, there you go. Right here at the bottom, and you can overlook at the bay in Miami. Unfortunately, that's not where I'm located or the engineering center is located. We're in the main campus itself, but it is where the next biennial meeting will take place. So really, really nice campus. You can even like kayak here, rent kayaks from FIU, paddle boards, etc., which is a really nice option to have. So just a little bit about FIU, because a lot of you may not be familiar with the university. So we are the #1 university, public university in the state of Florida. We're ranked top 50 in the U.S. News and Rankings for public university all over the U.S. And we're also the 4th largest in the US with about 54,000 students. That includes undergrads, graduate students, medical students as well. We have a law school, and it's a very diverse population of students, with about 68% being Hispanic and 11% Blacks. So we are also a very a commute school. So a lot of the students that attend the university live in the Miami and outskirts area. So fun facts about FIU. So our mascot's the Florida Panther. So here in Florida, we're native to this panther. It's literally called the Florida Panther. We only have it here. It's nowhere else found in the world. So FIU's mascot is the Florida Panther. And then another fun fact is that our American football stadium is named the Pitbull Stadium after Pitbull himself, Mr. 305. He's from Miami. So a couple years ago, they officially named it the Pitbull Stadium. So I think that's a pretty weird and quirky fun fact about us. So as far as research, so we're a Carnegie R1 university, which just means we're in the top 3% in research production. We have about 300 million in research expenditures last fiscal year, and we're number 16 in the most innovative public universities here in the US, according to US News and World Report. And we're also top 20 in the US for utility patents granted as well. So we have a lot of core facilities and recharge centers here. So, if you're a researcher and you're part of a large research group, then you may have, the ability to get a lot of, nice equipment to do your research. At FIU, we have here a lot of core facilities or recharge centers where anyone from any department can have access to different types of instrumentations that they can, pay for, or also collaborate with whoever is in charge of that center. Some of it includes Advanced Material Engineering Research Institute, or AMORI. This one's in the engineering center itself, and it allows you to perform SEM, amongst other things, to characterize materials at the nanoscale. At the Biomedical Engineering Center, we have a cell culture facility, also like a cryosectioning for tissue and imaging modalities that can also be used by researchers themselves. A trace evidence analysis facility, which you can perform elemental analysis using ICP-MS methods to quantify very small level or traces levels of metals or other elements of interest. And also our wall of wind. So, we are located in South Florida, which experiences a lot of hurricanes, and we have here I believe the only hurricane simulation center in the world. So we have, also an engineering center. It's called the Wall of Wind, which is funded by the NSF, and it can produce up to, I think, Category 5 winds to test a lot of materials of whether they can withstand these high winds created by hurricanes. So as far as cardiovascular research goes, so we recently just launched the Center for Innovation in Cardiovascular Health. It was announced literally like a month-ish ago. This is supported by the Florida Heart Research Foundation, which is a foundation here in Florida that supports cardiovascular research, and it's a nonprofit private organization that has committed this amount of money over the next 10 years to support specifically cardiovascular research at FIU and launch this center. So the center, a lot of this money is going towards the center to allocate for equipment and research materials to incentivize people to move to Florida and join the FIU and also the center if you're interested in cardiovascular research. Some of the equipment that was purchased was the Vivo F2 high frequency ultrasound, which can, be used for preclinical imaging. There's also part of this money goes to senior faculty grants. So if you're already an established cardiovascular investigator at FIU, you can apply to these internal grants to support your cardiovascular research. It also supports summer research internship programs for high school students where either the year before they graduate or right before they're joining as a freshman at FIU, they get to participate in 10-week long research programs in the summer to get some experience of what research is like. They're also giving nursing scholarships and also supporting students' works with stipends plus research supplies. And also, they're giving junior faculty grants, which is for young investigators like ourselves to start their lab and establish their research as new faculty members at FIU. So this center it's not just and it's not just hypothetical. There is a place for it. So this is a new building that just inaugurated a couple months ago as well. The center itself, so everyone who's part of the center and who does cardiovascular related research at FIU will be located here on the 6th floor. Right now, construction is undergoing in that floor, but we will have a lot of these core facilities for cardiovascular researchers to use, or anyone else outside in FIU as well. The building itself is ready, but the center is just starting the construction is just starting now. I'm not sure if it's going to be ready. Josh keeps saying that it's going to be ready by the end of the year, but construction can be really slow here. So maybe it's ready by ISACB time where we can have people like tour the labs and the open lab space and shared lab spaces, but I'm not too sure about that. But this is an incredible opportunity. And this is also like how I got funded to start my own research lab here at FIU. I received one of these junior faculty grants last year around June, and that's when I started my lab here. So I'll be talking a little bit about the research projects that I'm interested in. I don't have as much data to Carl to show because my lab is only a couple months old, but I'll be just talking more in general about some of the research projects that we're interested in and collaborations that we have going on and potential for collaborations. So, everyone knows here in this room, obviously cardiovascular disease is #1 killer in the world. I don't have to, be too morbid about this, but, one of the reasons why I think this is because there's a lot of risk factors, right, that contribute to cardiovascular diseases, such as obviously smoking, high cholesterol, diabetes, but also environmental agents and chronic diseases like kidney disease. So, cardiovascular disease can take decades to develop, and sometimes the symptoms are often subtle or often overlooked. And unfortunately, a lot of the times people are diagnosed when disease progression is very severe, and you're close to this chronic decline where there's not much you can do but manage the disease. but it's really hard to slow it down. So what we want to try to do is, instead of finding people when they're at the symptomatic advanced disease progression, you want to try to find them earlier, right, when they're at risk, when you could maybe either introduce lifestyle changes or also therapeutics to prevent this progression and this chronic decline, or delay this chronic decline. So one of the things that I'm very interested in is how can we identify then people at risk earlier, right? So in order to do that, we need to find markers of cardiovascular disease that are non-invasive. In order to identify whether these people are at risk. But it needs to be obviously markers that are easy to deploy in the clinic, right? You can't just give everyone that shows up an echocardiogram or a CT scan, right? And then if they're not symptomatic, right? And there's no need to do it, right? So then you want to be able to find early markers of disease that are non-invasive but can be easily deployed in the clinic in order to find these people. But obviously, it's very hard to find early markers in patients if they don't have advanced cardiovascular disease. So one way that we can do that is by identifying which markers. One way we can identify which markers to use is by using preclinical models of disease. So, if we take, for example, mouse models compared to humans, again, humans, it takes a very long time to develop the disease progression when you're at risk. But then once you're symptomatic, it advances very quickly. So if we use preclinical models to find these early biomarkers, instead of taking 30 plus years to study this in humans, we can study this in about 30 weeks in animals, which will allow us to identify which markers we could use for early disease detection. So in my lab, we're interested in two types of risk factors that advance and lead to cardiovascular disease outcomes. So one is kidney disease, and another is environmental agents, or environmental exposures, and how those advance cardiovascular risk. So once you have this two or in general cardiovascular risk factors, that lead to different types of cardiovascular diseases, the first diagnostic test or screening test really are either auscultation, so the listening of your heart sounds, an electrocardiogram, so looking at electrical signals of the heart, or also blood tests where you're really just looking at cholesterol levels, etc. So these are the initial screening tests that are usually performed in the clinic in order to identify these early markers of disease. So for blood tests, we're all pretty aware, right, of what's high and what's low regarding like your cholesterol levels, which cholesterol, good cholesterol versus bad cholesterol. There's pretty clear threshold, right, of when you're at risk whenever these numbers are altered. But when it comes to these cardiovascular signals, so phonocardiograms, so that's the heart sounds, or electrocardiograms, they're a bit harder to interpret, and there's not such clear cutoffs when it comes to, are you at risk of developing or having cardiovascular disease when you're looking at these two signals. So we know that in these two signals, structural and functional changes can precede right symptom onset, and they can alter both the ECG and the PCG signals, which would allow us then to take advantage of these signals and enable non-invasive early cardiovascular detection. This would be an improved screening strategy that disregards symptoms and finds patients that are in early need of cardiovascular workup or even treatment as well. So if we can take advantage of using these two signals at earlier stages, then we can find the patients that are at risk and monitor them throughout disease progression better. So one of the diseases that we were interested in to identify whether we could use these signals for early disease screening was aortic valve calcification. So the rate of aortic valve calcification, especially in end-stage renal patients, is 10 times faster than those without. So patients who have kidney disease develop aortic valve calcification much faster, and then obviously deteriorate much faster than the general population that develops calcific aortic valve disease. So it's important to identify patients that have calcific aortic valve disease and CKD as well at early stages, so that we're able to find them in this short amount of period that we have. So how is aortic stenosis, or really calcific aortic valve disease that then leads to aortic stenosis, identified in the clinic? So, the first signs is usually appear in a routine medical examination. It's when a patient either reports symptoms or the physician listens to a heart murmur, right? So through auscultation, they listen to a heart murmur. But a lot of the times this murmur can be, not diagnosed because either one, it's not there, which it can happen even at severe stages of aortic stenosis, or it can just be missed by the clinician. So one way that we can then one way that we can get rid of this or improve this screening in the clinic using auscultation is by looking directly then at the phonocardiogram signal and looking at the second heart sound. So I told you that there's this murmur that arises in aortic stenosis, but it may not be there all the time. But your first and second heart sound are always there as long as your heart's beating, right? The second heart sound is produced by the closure of the aortic and pulmonary valve. And the idea is that, if there's structural changes in the aortic valve due to the presence of calcification, then are there changes itself in the second heart sound characteristics that could lead us to find these patients. So as I mentioned, it's hard to find patients early in the clinic early, especially for calcific aortic valve disease. So how we studied whether we could use the second heart sound as an early biomarker of calcific aortic valve disease was using an animal model that developed both kidney disease and also calcific aortic valve disease when fed a high adenine diet, and then supplemented with a high phosphate diet. So we recorded PCG signals at the end of the regimen, and also performed echocardiography and looked at aortic valve calcification using OsteoSense, which is a calcium dye tracer, to determine whether we could use the second heart sound as an early biomarker of calcific aortic valve disease. And what we found was that first, that yes, this mouse model developed calcific aortic valve disease, which was not reported before. And here you can see that the left coronary, right coronary, non-coronary leaflets are severely calcified compared to our healthy control and just our CKD without calcification control. And we can also see here on the right that the velocity and pressure, aortic valve mean velocity and peak velocity, as well as pressure, was altered in the group with the calcification, with actually lower pressures and lower velocities, which is something that could occur in low gradient, low pressure aortic stenosis patients, so a subpopulation of patients with aortic stenosis. So then to our question of interest, so this model develops, calcific aortic valve disease, not so sure about aortic stenosis, but there is some sort of functional changes. Then next we wanted to see, okay, can we use the sound to find these or to detect calcific aortic valve disease? So what we did is obviously we recorded the signals in these mice, and then we segmented all cardiac cycles, and then time aligned our second heart sounds, and we were able to patent this method in order to then prepare. So then we performed this method in order to prepare the signal for further analysis. And then what we did was we fed all of the signals or a subset of mice, so the training set of mice, into an algorithm, and we classified it based on whether the animal was healthy, so there was no calcification and they were just on this regular diet, whether the animal had CKD without calcification or whether the animal had CKD with calcification. What the idea is to train the algorithm on these diseased heart sounds, and so in order to be able to then predict whether a new heart sound would belong to any one of these three groups, with the group of interest again being those with the calcific aortic valve disease. And what we were able to find then using a new set of sounds from new mice was that the second heart sound was able to predict accurately about 97% of the time if the sound came from a healthy animal, so right from a control animal. And with about 85% accuracy, it could predict the presence of aortic valve calcification. So what's important to note is that this model, yes, it gets calcific aortic valve disease, these mice, but it's very, very early stages. It's very mild calcification. So the leaflets are not, completely calcified as you would see in a patient with late stage aortic stenosis. Which is why we think that, this is a feasible approach in order to find early markers of calcific aortic valve disease just using the sound, because again, the leaflet is not severely calcified as it usually is with late stage patients. Interestingly enough, we were able to then predict the values or with about 90% accuracy of sounds that came just from CKD patients. So we think there's, or not CKD patients, CKD mice in this case, meaning that there's probably some other cardiovascular outcome just due to the CKD alone that's altering heart sounds as well. So, the question was, can we use the second heart sound to characteristics to find calcific aortic valve disease at early stages? And we were able to show that in this dietary mouse model of CKD that developed aortic valve calcification, we were able to use these second heart sounds to predict about 85% of the time whether they were diseased or not, which showed that there is the feasibility of maybe doing this in the clinic, right, or using this approach in the clinic in humans in order to find early stages of the disease. And this is kind of where we're going to next. So I'll just play this video in the background, but I won't if it plays. But hold on, let me. Well, it doesn't want to play now. That's okay. That's funny because we tested it and it was fine. But now we're moving into the clinic with this project. So FIU, we have a medical school, but we don't have a health center. We're not a hospital. So we have a partnership with other hospitals here in the South Florida area, one of them being Baptist Health. So Baptist Health is South Florida's largest not-for-profit healthcare system. And we have a collaboration with them to expand not only physician training from our medical school, but also research and patient care. So what we're doing now is, and it's a publication that a news video and article that came out a couple of days ago at NBC6, so the local NBC channel here in South Florida, where we're talking about partnering with Baptist Health to go into the clinic, record heart sounds of patients that are going to the clinic just for checkups and are getting some sort of either echocardiography or cardiac CT scan. And we're also recording their heart sounds to be able to develop the database that's able to feed the human algorithm, right? And so that we're able to then translate this technology from obviously the mice to the clinic and to be able to work with human patients. So then, here what we hope is that this project, obviously once we move it into the clinic is, that it enables us to have a scalable screening strategy that can detect patients with calcific aortic valve disease for management, not only in the clinic, but maybe outside of the clinic. with something as maybe having a digital stethoscope, sent with the patient at home. The patient, records their own heart sounds, and then the algorithm is able to predict whether they're doing well or they're not doing well, right? In terms of disease. So that's one of the projects. And then another project I'll just talk about very briefly has to do with environmental exposures that affect cardiovascular disease. So a couple of years ago in 2023, 2021, a couple of statements came out from the American Heart Association saying that contaminant metals, which is arsenic, cadmium, and lead, contribute as a cardiovascular risk factor. So we know that if you're exposed to these metals, even at very low levels for a chronic period, then your chances of developing different types of cardiovascular risk significantly increases. However, we're not really sure how these metals interact, right, with not only the heart, but the vasculature, and how they induce these different cardiovascular diseases. So the mechanisms are not very clear of how exposure levels, sorry, especially low levels, go how you go from low exposure levels to these subclinical and clinical outcomes. And a lot of the reason why we're not really sure of the mechanisms that lead to disease is because there's not a lot of publications out there on animal models looking at how heavy metal exposure induces cardiovascular disease. So another project that we started at the lab, and this is in collaboration also with the public health here at FIU, is to develop animal models of both lead and cadmium toxicity that will allow us to study these cardiac and vascular changes that contribute to the development of cardiovascular disease. And the goal is for this project is to identify how dosage and exposure durations influence cardiovascular and vascular remodeling, how exposure to one of both metals influence and or accelerate cardiovascular progression, and then also observe how changes in these models compare to clinical observations from human patients, with the goal of being to establish these models of cardiac toxicity in order to pay future studies and investigate the underlying mechanisms behind this risk factors. So that's what I'm doing now in my lab. We don't have any data yet because six months into having a new lab, and we're just coming up and doing experiments now where we leave these animals for quite a long time, from birth up to 32 weeks of age, on these different concentration of diets. And what we're doing radiotelemetry implantation to look at blood pressure changes and also ECG changes over time, performing echocardiography and cardiac catheterization procedures to look at PV loops and overall cardiac function and how that changes, to determine at which time point and at which concentration these animals start developing cardiovascular disease. With, again, the idea for this project as well, and in the future, once we develop the animal model, to identify the markers that we can use in order to early markers that we can use in order to identify these different types of diseases that metal exposure could contribute to as well. And with that, I'll leave you, if you have any questions, I'm happy to answer them. This is a couple of pictures from folks in my lab. Like I said, I'm 6 months into it, so there's a lot of fun stuff, a lot of struggles, but I hope that by the time ISACB comes around, I'm ready to show you guys a lot of data. I know I'm personally ready to show a lot of data, so I'm looking forward to that.
Thank you very much, Valentina, for your presentation. It's now time for questions. So if someone want to ask something, I'm looking on the chat if there is any question. I think we don't have.
So I would have a question. So thanks a lot. I think it's really interesting that you're focusing on the prevention and not only on the treatment. But for your mouse models, I have a question. Do you think that it's at some point possible to combine some of these environmental risk factors together to kind of not treating but exposing your mice, like for example feeding them a high-fat diet, in addition expose them to cigarette smoke, something like that, so that you can evaluate multiple risk factors?
It is interesting. I like diagnostics better, but I will tell you that therapeutics, people like the story of therapeutics better, right? Because then it's like, oh, you find it early, so what? And I was like, well, some that we find it early, then we come up with a therapeutic for earlier, right? So yeah, so some people have looked at some environmental exposures, like even cigarette smoke, in combination with high fat diet, and even some with arsenic. So there's a study out there looking at arsenic in ApoE mice, which they're have issues trafficking their cholesterol, right? And then when you feed them a high-fat diet and when you feed them arsenic, it even accelerates calcification, vascular calcification, right? So there are some models looking in the arsenic, not in the cadmium and lead, which is why I decided to go that route. But yes, eventually the goal would be to look at, some of the interlinks of this risk factors and see why is it that in my opinion what happens is like it accelerates, right, disease progression when you're exposed to these several risk factors. And then is there a way to mitigate for that, right? There's only so much you can mitigate for, obviously, if it's cigarette smoking, right? But in terms of sometimes cadmium and lead, it can be in your drinking water, it can be in the environment you're in. Can you move? Can you afford to move, right? There's a lot more public health issues on that side, but yes.
Thank you very much. I think Carl has a question.
Carl has a
Yes. Congratulations, fantastic work. I really like your focus on the work you're
Thank you.
doing. So I have actually two questions. One is a very simple question: how close is can you use with if you look at the heart rate of a mouse, how can you translate this to a human?
Right.
Is this more
Yeah, it's a
easy
lot
than
higher.
because
Yeah, so pressures are the same, which is good.
Mhm.
Pressures 120, 120 over 80. Pressures are the same. Heart rate is much higher. It's about 600 beats per minute. So it's a good thing and it's a bad thing. It's a good thing because in about a minute you get 600 beats to analyze versus in humans you need, like a whole hour for that amount, right? But the pressures are the same, there's four valves. Obviously, velocities are a bit different, but like, pressures in the valve are the same. Transvalvular pressures are the same. Quote unquote ECM cellular populations are the same, right? Obviously, quote unquote, there's differences in sizes, much, much smaller. So we think that it would be feasible that, especially the heart sound stuff, right, to translate to humans because it is so similar. Obviously we have to
You have
go
to
into
start
the
somewhere.
clinic, and right in the clinic the issue will, I think, become there's a lot more variability, right, between patients. Right, like I know, for example, when I listen to my heart sound, it's barely audible. I have really low heart sounds versus like someone else, right? So I think in the clinic we'll run into those issues, and also the fact that a lot of people may have, not only one cardiovascular disease, but others that also alters heart sounds in other ways, right? But there's a lot more research now in the heart sound field, right? Using AI and machine learning algorithms, because it's gotten a lot cheaper to have these supercomputers, right, that are able to analyze these big databases. So I think it's still feasible, right? It's just a matter of how much data do we need, right, to feed the algorithm? How accurate, does it need? How much, variability in our disease stages as well, right? Like if I have 100 people that are early stage disease versus, I don't know, 2000 at late stages. Obviously, my algorithm will be much better at the late stages of disease. So it's a matter of probably building the database, and with a big enough database, I feel comfortable that we'll be able to translate that.
That leads me to a second question, if I may. Just
Yeah.
because speaking about data, what did you think, or is there a plan to use the health data from wearables like the Apple Watch or any smartwatch, which is capable of
Yeah.
doing these heart frequencies and ECGs? And of course, its data protection is important. But if there would be a group
Right.
which uh, which
Yeah,
which
so
which
for the
provide the data.
ECG stuff, it'll be pretty easy, right?
Mhm.
The hardest thing becomes getting your true positive. Like what, like obviously everybody, I'm sure everybody here has some sort of wearable, right? A lot of people have some sort of wearable, right? Whether it be a Fitbit, an Apple Watch, a Ring, whatever that's able to track these signals over a long amount of time. So you have a huge data set. What becomes really hard is, do you have that test that tells you whether you're a true positive or a true negative, right? So you can give me all your data, but if I don't know for sure if you have heart disease or not, is it really useful? Right? Not really, right? Like I have to have that other imaging modality that confirms whether you have heart disease or you don't have heart disease. Right. So while it's useful, then it's not useful for building the algorithm unless you have those true positive or true negative values that come from other tests. So that where it becomes really tricky, right? So that's why a lot of algorithms that have been developed for ECG, for example, it's using database from the clinic. So let's say patients ECGs, you can record them and store them in medical records much easier than digital heart sounds, for example. So then a lot of databases are built on ECGs for medical records that patients also, for example, had a CT done or had an echo done, and then you have that true positive or true negative value for another imaging modality. So, long story short, like yes, you can use the data, but it would only really useful if you have the imaging modality. And that's what, as a researcher, unless you're taking it from medical records, it also becomes really expensive, right? Because then I have to pay for you to go get this imaging modality that maybe you don't need.
Thank you.
Mhm.
Thank you very much. Is there any questions in the audience or not?
There's one in the chat.
When is the
Oh,
chat?
yeah, yeah, yeah. How am I
Uh,
controlling for sex differences? Well, I don't control for them. I just account for them. I have, male and female mice. And obviously with the mice, it's a little bit easier, quote unquote, right? You have the same amount of males, same amount of females. You don't have so much control of body weight differences in mice, although I feed them the same diet for the same amount of time. Doesn't mean they're all gonna gain this or be around the same body weight. So the mice, obviously it's a much controlled study, but like I mentioned, when it comes to the humans, I can't really control it either. I can just account for it when building the database. So we're having, other factors go into it that could, influence it, like BMI, although I hate BMI as a measure of anything, but but something to keep in mind, as well as, do they have, for example, high blood pressure or not? So those are things that we're taking into account, but we're not sure yet how much they'll influence the characteristics of the sound themselves. So it's something that we have to keep in mind when going into the clinic. Hope that answered the question
well, yeah,
correctly.
thank you. Thank you very much. I think we are done. First, I wanna thank you both of you for your excellent presentation. It was really good to see you. I'm really looking forward to seeing you at Miami at the end of the year. So if there is any announcement from Andy, or we can maybe do it in another session. Andy?
Yeah. Again, I just want to echo what Fabian said. Thank you both, Valentina and Carl, for sharing your work. This is a great way to kick off 2026 and kind of showcase what young investigators involved in ISSCP are doing. Again, we're promoting our biennial meeting in Miami. That is in November. Correct me if I'm wrong, it's the 11th through the 14th. Abstract submissions, the portal, I think, for that just went out. And also, if you're interested, you're a young investigator yourself and doing one of the webinars to showcase your own research, please reach out to the Young Investigator Committee. But yeah, thank you so much, and hope to see you all next time.
See you at the next webinar or and hopefully the meeting.
Yes.
Yeah, see you soon.
Thank you. Bye.
Bye.
Bye.